Hi everyone, my name is Cindy Jones. I'm an Associate Professor of Behavioral Sciences at the Faculty of Health Sciences and Medicine at Bond University in Australia. I'm also an Adjunct Research Fellow with the Menzies Health Institute, Queensland at Griffith University in Australia. Now, first of all, I'd like to express my gratitude and appreciation to the Conference Organizing Committee for inviting me to give a presentation at a conference. Now, today, the title of my presentation is Enhancing Care and Well-Being of Older Adults via Assistive Technology. So without further ado, let me start with my presentation. So in my presentation today, I'm going to be giving you a definition of what is assistive technology, and also look at a different type of assistive technology. In particular, I'm going to be presenting some of my aging research involving telepresence and social robots, which is a form of socially assistive robotics. And also, given my research in the area of socially assistive robotics, I'm going to be presenting you some of the enablers as well as challenges to the adoption and implementation of socially assistive robotics in aged care. Specifically, I'm going to be presenting my paper, which discussed the feasibility in the use of DreamPad within an aged care setting. So what is assistive technology? According to the World Health Organization, WHO, Global Cooperation on Assistive Technology, assistive technology is basically an overarching umbrella term that covers any systems or services related to the delivery of assistive products and services. Now, when it comes to assistive product, we're talking to any product, whether it's a device, an equipment, instrument, or even software that are either specifically designed and produced or generally available with the primary purpose or goal, which is to maintain or improve an individual functioning, independence, and thereby promote their overall health and well-being. So what are the different types of assistive technology? In Australia, within our National Disability Insurance Scheme, we have different categories of assistive technology, as you can see on this slide here. Assistive technology category range from things related to beds and bed equipment, to communication aids, to even things that provide hygiene care, assist in the lifting, transferring of patients, to even things like walking mobility aids, and including devices or equipment like wheelchairs, scooters, etc. So I'm not going to go into every one in details, but as you can see from this slide, there's wide numbers of categories of assistive technology that cover a range of products and services. Now, when it comes to robotic assistive technology, in healthcare, there are three main types of robotics which are worth mentioning. So the three main types are rehabilitation robotics, assistive robotics, and socially interactive robotics. The first type, which is rehabilitation robotics, really focuses in the pursuit of the recovery or regaining impaired motor function. The second type, assistive robotic, AR, are actually intended to substitute or compensate for any missing motory or sensing skills. While socially interactive robotic, SIR, are primarily involved with human behavior through robotic companion, speech, and gestures. Now, I do a lot of research in what we call socially assistive robotics, which is a very interesting area that represents an intersection or interplay between assistive robotics, AR, and social interactive robotic, SIR. So the work that I do relates mainly with social assistive robotic, which is a crossover between AR and SIR. Let me talk a little bit more about socially assistive robotic. Socially assistive robotic acts as a social mediator for human-computer interaction as well as human-robot interaction. Now, basically, socially assistive robotic is defined as an artificial agent that is embodied with features of a human or an animal. Now, in my research in the use of assistive robotics to improve health and well-being, care and care provision of older people in aged care, I engage in research that focus on socially assistive robotics, and there are two main types that I focus on. One is telepresence robot, and the second type is social robot, also known as companion robots or social companion robots. With telepresence robots, it actually focuses on human-computer interaction. Now, it actually established connection between the telepresence robot, which is usually located where the older person or the older patient is found, all right? And what happens is a remote user, usually a family carer or a health professional, via the internet, using specialized software that is downloaded on their computer, which is at home or at a workplace, will then establish connection with the older person or the patient via the telepresence robot itself. Okay, so that's why it's a human-computer interaction. Now, the next type of socially assistive robotics is social robots or companion robots, social companion robots. Now, this type of socially assistive robotic focus on the human-robot interaction, where it assists people through social interaction rather than physical interaction. So an older person may be given a social robot to promote social interaction or interaction between the human or between the older person and the robot. Or what can happen is there could be another form of social interaction where the robot itself helps to facilitate social interaction between the older person with somebody else through conversation about the social robots. That's why social robots is about promotion of social interaction rather than physical interaction. As I mentioned, my area of assistive robotic research focused primarily on socially assistive robotics, and there's two types, telepresence robot as well as social robots. So here I'd like to actually have a deeper discussion about telepresence robot. Now, telepresence robot were first described in the literature as a human machine/computer interface. Now, telepresence robots do not possess autonomous behaviors, and therefore they require a remote user to operate them. Through the telepresence technology, the operator can virtually see into another space through a two-way camera and can operate the robot via software on their computer, as I described earlier. Now, therefore, through this approach, the operator can feel that they are physically present at the location of the robot, no matter where the robot is located. Recent advances in information and communication technologies have even further facilitated the development of telepresence robot for consultation in healthcare as well in the education sector. However, given the newness of this technology, there are few noteworthy research paper available and also discussion on the use of such technology with older people. It's only really in recent times that you're starting to notice there are some research paper published in the use of telepresence robot, the use of such technology with older people in care. Now, on this slide, I have listed some of my recently published articles on telepresence robot, on research that I've conducted with my mentor as well as my colleagues over the years. Now, on this slide, you can also see two different telepresence robots. You got a white one, which is called Vigo, and a blue one, which is called Giraffe. Now, on this picture, it doesn't look like there is that much difference in size, but in reality, the blue robot, Giraffe, is actually a much bigger robot than Vigo, which is the white one. Now, there are distinct features between the two telepresence robots, and there are pros and cons. For example, the white Vigo robot, it's actually quite streamlined, fairly small, so it actually are quite agile in its movement, and given the size, it actually maneuvers really well in tight confined spaces compared to the blue telepresence robot Giraffe. Now, Giraffe, as you can see, is a little bit more rounder, is actually wider. So in terms of movement, Giraffe doesn't move as well, or is not as agile, is not as good in confined spaces compared to Vigo, the white telepresence robot. However, we found Giraffe, the blue telepresence robot, to be far more usable compared to the white robot Vigo. And the reason because the Giraffe robot with the bigger screen actually facilitate conversation or connectedness much better than the smaller screen on the white Vigo telepresence robot. Now, beside the larger screen, what is also unique about Giraffe, the blue telepresence robot, is the screen actually tilts, okay? And the screen can also move up and down wherever required. So you might have an older person sitting down, so the screen can come down, or an older person might be standing up walking and the screen can go up and walk along with the older person or patient. But more importantly, if the patient is lying in bed, the telepresence robot, the blue one Giraffe, the screen can actually tilt so that whoever is operating it can look down at the person who might be lying in bed. So maintaining the eye level. So when the older person is sitting down, telepresence actually, the Giraffe, the blue one, the screen actually moved down. It stopped neck strain from older person who is sitting down having to look up at the screen. So there are both pros and cons to Giraffe and Vigo. But the additional features in the moving of the screen up and down, the tilting of the screen and the larger screen makes it a lot much more user-friendly than Vigo that has a smaller screen, despite the smaller size and agility of Vigo. What we know is older people that have used Giraffe really like the big screen because they express that they can see their family or the other person by the screen much more clearly than the smaller screen on Vigo. So the size of the screen really do make a difference here. Okay. So beside the telepresence robot, the other type of robots is social or companion robots, or even social companion robots as such. Now, we've done a lot of research in social robots and mainly on Pyro, which is the robotic seal you can see on this slide. Now, Pyro, some of you might have seen it before, some of you might not. Pyro is a social robot that has been developed in Japan. Now, it was originally developed for use by children with autism, but then it was introduced to older people, including people living with dementia in long-term care, to look at the impact on their engagement, their behavioral psychological symptoms of dementia, as well as on their emotions or their affect as such. Now, Pyro is really unique because it has a lot of tactile sensors played in it. And basically, Pyro's head actually moves. Okay, the eyes actually open. It actually reacts to light. So when there is bright light, Pyro recognizes that it's, the day, so it will open the eyes. And if it's dark, it will recognize that it might be nighttime. It closes its eyes. And Pyro, you can stroke the back. It can also stroke under the belly. and it will have a reaction where the head will move and it will make a noise. And you can also stroke its fins and also its end-tail fin as well, and it will induce a reaction. And with pyro, if you hold it really tight, it can actually even vibrate or even shudder to let you know that it's uncomfortable. Now, pyro is really cute. The way you charge it is actually through a pacifier that you put in its mouth. And also the whisker, as you can see here, also creates, or actually you can touch the whisker and it's like a tactile sensor in there too, and it will move its head and respond by moving its head, closing the eyes, or making sound as well. And pyro is equivalent to the weight of a newborn infant on average. Okay, a really cute little social robot, and it has antibacterial fur as well. The upkeep of the robot, it's really easy. Some antibacterial spray and stroking with a comb, and ensuring that whoever use it, sanitize his hand before and after use of pyro. Now, we were very fortunate, or I'm very fortunate to be part of a team that was led by my mentor, Professor Wendy Moy, where we actually got a large funding from Australia Medical Health and Research Council, over $1 million, to conduct a multi-year randomized control trial in the use of pyro on engagement, affect, and behavioral and psychological symptoms for people living with dementia in aged care. We were the first RCT, large-scale RCT, that actually researched on over 400 people living with dementia, living in long-term aged care in Australia. It was the largest study of its kind at the time, and I believe this is still one of the largest study on social robot, particularly pyro. Now, we have published quite extensively. Listed here are just 8 of the articles we've published from the grant on pyro, and as you can see, there's a lot of different publication from protocol, the primary outcomes, secondary outcomes, to qualitative studies, to cost effectiveness study, as well as qualitative study in terms of the perception of the use of pyro. Now, in general, we found evidence to support the use of pyro in engaging people with dementia and actually leading to positive affect or positive emotion for people who are using pyro. However, we yet to establish robust evidence to suggest that the use of pyro reduces behavioral and psychological symptoms of dementia, such as agitation or wandering. Basically, further research are needed to examine that. And from our study, we also raises the question of, trying to do more research in the future to determine, how pyro or who pyro works well with, the type of people living with dementia. Does early stage people or people with early stage dementia respond better to pyro, or those in mid to late stage dementia? Does their level of agitation really make a difference to their level of engagement or their experience with pyro? And also finding out, is pyro better in a group setting, individual setting? How often should pyro be used? Leave it 24 hours with the person living with dementia, or is it 3 times a week, half an hour per session, 1 hour session? What is the dosage, the frequency? So while we have established some preliminary evidence about the use of pyro, but there is further work to be done in terms of dosage, frequency, the characteristics of people living with dementia or older people that will benefit more from the use of pyro. So there's a lot more further work involved. As I said, there is also a paper on the cost effectiveness, and we actually found that pyro is relatively cost effective when you compare to a live pad, or even to, say, a plush toy without the robotic features. So I won't go into details of all of this. I've just given you a brief summary of the key outcomes. So if you're interested, there's a lot of published paper that we have actually published over the years, and it's listed here. So feel free to look up on it. All right, next on this slide is to show you the different type of social robots beyond just Pyro. There is Neo, there is Pepper, there is Abio, there's JustoCat, there's Pepero, and there's also Pelro. Now, I'll briefly talk about each of these types of social robots. And obviously, if you type it on Google, you can find out a lot more details on these robots. So Neo is a world-leading and most widely used humanoid robots for education and research. Basically, Neo is about 58 cm, tall, autonomous, fully programmable robot that can walk, talk, listen to you, and even recognize your face. Then we also have the next type of robot, which is Pepper. Now, Pepper is the world's first social humanoid robot able to recognize faces and basic human emotion. Pepper was actually optimized for human interaction and is able to engage people through conversation and the touch screen that is on its chest. And Pepper is originally developed for use in the aviation industry, in airports to guide, I guess, passengers, etc. But then it's been, trial in aged care with interesting results. Now, the next one is Abio. Abio is an artificial intelligence robot in the shape of a dog. It's basically a robotic pet that is also developed by Sony in Japan. It's very popular, very cute, very responsive, and it's actually developed back in 1999. Reception to Abio has always been fairly positive, but there's not enough research evidence to demonstrate its efficacy in an aged care setting as such. In fact, Abio was discontinued for a number of years, but in recent year, I think it was last year, they went back into production. So Abio is also another very interesting social robot. Now, next we also have other types of robot, and the next one I'd like to talk to you about is actually JustoCat. Now, JustoCat is a therapy cat. I've actually had one where I've interacted with. I'm not a big fan of JustoCat. As you can see, it looks more like a plush toy rather than a real cat. It looks more toily than, the look, rather than resembling the look of a real cat. It doesn't feel very plush. It feels more like a robot. You can feel the hardness in it, and it actually only move in a certain way, and when it move, you can actually hear the mechanical sound in the movement. So I'm not really a big fan of JustoCat, but if you have a chance to experience it, you might have a different experience, or you might feel differently to me. Then the next one I'd like to talk about is Pelro Robot, which is a bipedal robot developed to keep you company. So Pelro Robot can be used to watch and communicate with family members remotely, can bring you the news, weather, calendar as well. It was originally designed for senior citizens to prevent dementia and make them more independent. All right. Then there is also Pepero, which stands for Partner Type Personal Robot. Pepero uses different technologies to interact with its environment. For example, its eyes has twin camera with face recognition system. Pepero does not do much. It just roams around looking for faces. Upon finding one, they'll try and start a conversation. And Pepero also, besides having a face recognition system, also has a speech recognition system. So with a pair of sensitive microphone, it can determine exactly where the sound comes from, if the sound is human, speech, and then the robot will interpret the information and respond accordingly. And while it's roaming around, it uses an ultrasound system located in its chest to detect objects. So if there's an object that lies on its path, it will know to stop or avoid hitting the object as such. So basically, Pepero, it has face recognition, speech recognition, ultrasound sensor to to help facilitate conversation. Okay, so these are some of the social robots. By no means are these an exhaustive list of social robots. There's a lot more, and as you know, as technology improves, more and more different types of social robots are being introduced. But we just have to be a bit mindful, because rather than rushing out and buy this to be introduced for use by older people in an aged care setting or long-term aged care setting, we got to be a little bit more cautious, because a lot of these robots have only preliminary evidence to suggest its viability, efficacy for use. So the evidence today are not that robust for clinical use as such. So just be mindful of that. So in this slide, what I like to highlight are some editorial or review articles regarding social robots. Now, these articles, I'm one of the co-authors, and it was actually published with my colleagues, my mentor, and my PhD student. So the one on the right is about the effectiveness of social robots for older adults. It's a systematic review meta-analysis of randomized control trial. It's a very highly cited systematic review, even to today. It was only published in 2018. And basically what we found is that social robots appear to have the potential to improve the well-being of older adults, but conclusions are limited due to the lack of high-quality studies, and it's recommended that more randomized control trials are recommended with larger sample size and more rigorous study design. At the point when this systematic review was published, the only randomized control trial on the larger size scale was the one that I was involved with my mentor and colleagues, which was funded by the Australian Medical Health and Research Council. Now, another PhD of mine, student of mine, and my mentor, this student is actually from Taiwan. She published a systematic review on social robots for depression in older adults. Now, basically, this systematic review highlights the potential of social robots intervention in reducing depression in older adults. However, again, the evidence that is out there is still not enough to formulate recommendation on clinical effectiveness. And so basically, the couple of systematic reviews so far on social robots suggest that there seems to be preliminary evidence about its efficacy that seems to indicate the potential of the use of social robots with benefits for older adults. But before we can, confidently recommend, we need more robust evidence. More studies needs to be undertaken. Now, one of the editorial piece that was published, which I was involved with my mentor, was about the design of social robots. And from our work over the years with social robots, we are actually calling for the use of a user-centered research design in developing and guiding the use of technology, including robots in aged care. What we found is a lot of robots were developed by robotics engineers with minimal understanding and little input from healthcare professionals who are involved in the care of older person. So robotic engineers, they develop something which they think will work with older people. They spend all this time, money, develop something, then hand it over for research, for testing. And then we found there's all this issue or that could have been circumvented if health professionals were involved, consumers were involved in the consultation, in the development, in the production of a prototype. So it's about a user-centric where the involvement of key stakeholders from aged care organization, researcher, healthcare professional, consumer, family members of consumers. If we had the involvement of these stakeholders in the design, the development of a social robot, it would have been more effective than just robotic engineering just coming up with an idea that they think will work and then designing and producing a prototype for testing. That we feel is counterproductive. We believe in a user-centric approach. All right. So on this slide are a couple of other social robots that we have done research on. One is social robot Cutler. This robot was developed in Singapore, and we were given one to trial and do some research on. Unfortunately, the reception to Cutler wasn't great. A number of reasons. When you look at Cutler, and if you were able to touch it, you feel that the padding is really thin, and you can actually feel the robotics just touching on it, the robotic mechanism inside it when you touch it. And it's very stiff, very hard, very heavy. It's not something you can hold or put in your lap. You got to literally put it in under the table, so you can only interact with it sitting on the table. Unlike Pyro, the robotic seal, where you can hold it and cuddle it towards you, it's really hard with Cutler. And interesting comment. Now, an interesting comment that participant made is, oh, why are you giving me a teddy bear? I don't want to play with a teddy bear. Teddy bear are for my grandkids. I don't want it. So teddy bear is associated as a toy for children. It's not something that older people are receptive to as a companion robot as such. Unlike, say, Pyro, which is the robotic seal, I probably didn't really say earlier on why is a seal. Some people might be thinking, why not a dog, why not a cat? The reason why the developer decided to go with a seal is because seal is seen as a neutral animal. It doesn't induce positive or negative feeling on the get-go. Unlike if a cat or a dog, some people might like a cat, some people might not. Likewise with a dog. For example, I'm scared of dog. Give me a dog, I'll be petrified. And similar for a cat. So a seal would have been a neutral animal that is likely to evoke negative or positive emotion in the user as such. So with that in mind, Cutler is more associated as a toy, a teddy bear for children, so that did not go well with older people. Now, another type of technology is virtual forest. Now, virtual forest program is one that we were given to test as well. It's basically a program which is a peaceful, enjoyable, immersive environment that is designed to specifically improve the quality of life for people living with dementia in long-term care. Now, the virtual forest is actually engaging, empowering, and explorative. It actually presents an expansive park-like settings where there are 4 seasons that can change with the clap of the hand. And it uses an all-back motion sensor that allows the user to provide input with nothing more than just a wave of their hand. And this means user can use natural, easy motion to control interactive elements in the forest. So the interactive elements of the program are designed to give some control to people living with dementia. It's their forest. They can experiment with it and they can enjoy it. So when they move their hands, it can cause a boat to come into the river, or it can lead to a dragonfly flying in, etc. Now, sounds like a great idea. And in fact, what we found is some people did enjoy it, but there is a problem with it, or there's an issue, which is a little bit of a concern, is that in order to be immersed in this experience, the older person need to have movement and motion. So their hands have to be raised and moved on constantly in order for that immersive experience to continue. The moment they put their hand down, like the boat will go out of the screen, the dragonfly will move away. So if you think about it, they can't engage in it for over an extensive period of time. After even a couple of minutes, for some of them, they get really tired. Older people are frail. They don't have as much energy as they used to. So, constantly having to raise their arm for quite a period of time, that becomes a bit of a struggle for quite a number of older people that we tested the virtual forest on. So something to remember. So Cutler virtual forest did have potential, but each have its own problem as I've just described. So overall, with all our experience of researching social robots for use by older people in aged care settings, we have identified several enablers and barriers to the adoption and implementation of social robot in aged care. So I guess one of the barriers is the attitude that is social robots meant to be a substitution of human care? Is it to replace the essence of social and physical human interaction with robots? Now, that's not the intention of social robots. What we recognize that social, physical, human interaction is still best for older people. But as you know, in a current environment where we have an aging population, increased care burden, increased demand for aged care, where there is limited aged care or limited health workforce in the aged care, let alone having people interacting with older people in care over an extended period of time. There are also research that have calculated the number of minutes an older person in aged care, for example, in Australia, will spend interacting, and the minutes is real. The proportion of time is really dismal and appalling. Now, in the absence of having people to talk to or interact, what could we do in place to fill the gap? Not so much to replace, but to fill the gap where has been identified. And social robot could the intention is for social robots to fill the gap, not to replace it, to fill it wherever is required. All right. So I just emphasize it's never about replacing it. It's to provide alternative or to fill wherever there's a gap in, recognizing that as much as possible, human interaction, social interaction with humans is still best for older people. Now, there is also concern about the intuitiveness of social robot, especially when there's unpredictable event associated with aged care. Yes, we acknowledge that social robots probably are not intuitive unless there is some sort of alarm system that can be set in the social robots. But in a lot of different things that we give older people, they are not necessarily intuitive in any forms, ways to react to unpredictable events. So it's not really, I guess, reasonable to expect social robots to do everything. Yes, there are concerns with the over-reliance of use, so try to avoid using over-relying social robots as a replacement for human interaction, as I said before. There's also concern about social robots causing emotional attachment if the user. Yes, the use or the introduction of robots can lead to emotional attachment, but emotional attachment of the older person can occur with another person, can occur with social robots, can occur with an object itself. So we're not going to be able to give them something that doesn't cause emotional attachment, and that's the key element to social interaction, the emotional aspect. So we don't see that as being a real issue. There are also concerns about social robot increasing disorientation in people living with dementia. We haven't actually experienced in that, but we don't actually feel that that's an issue. There are also concerns when it comes to ethical consideration, where people raises that we are lying or we're deceiving the older person, thinking it's a real dog or a real animal as such. Now, that's not the intention. When we introduce social robots to our participant, we always make it very explicit. Now, this is a robotic seal. We actually say it's a robotic seal. We don't say this is a real seal for you to interact with. We don't lie. We tell it as it is. We try and maintain their dignity by not forcing them if they don't want to. That's fine. We just move it away from them. It's the choice. It's a person-centered choice on their part. So often the concept of substitution of human care with different concerns, as I've listed here, as well as ethical consideration, do act as a form of barrier to the adoption and implementation of socially assistive robotic that include telepresence and social companion robots. Now, what we think is important to enable the adoption and implementation is to improve the knowledge and attitudes, not only in health professionals, but even families, users themselves. Okay, it's important to tell them and make them be aware and be knowledgeable about the benefit, how these social robots works, and also change the attitude about the cost, because some of these robots may not cost as much as they think it is. Now, obviously, since we're talking about cost, the cost effectiveness is also important. As I said, with Pyro, we've done a cost effectiveness analysis, and we actually found that it's actually quite cost effective. Because people get concerned about the cost of the robot, the startup cost. Yes, social companion robots are not cheap. They are in the thousands. Like Paro costs about US $5,000. Neo costs US $9,000. It seems like the upfront cost is high, and there's also concern about replacement costs, ongoing support costs, or even advanced technology over the years that makes the existing social robot becoming obsolete really quickly. Yes, there are those concerns. But when we look at the cost, if you look at the cost of a social robot compared to the cost of, say, for example, having a pet in a nursing home, the cost of buying a dog up front is expensive. It's already a few $1,000s, can be, depending on the breed of the animal. Then you got insurance, health insurance for the dog. If the dog is unwell, you got to take it to the pet. But most importantly, what we found is for nursing home that has a dog, we have heard of stories and reports where the dog get overfed because everyone is feeding it. It gets really stressed and overstimulated because the older people, quite a number of them, is actually interacting with it constantly. It's not given sufficient rest. So there is, I guess, the well-being of a real animal is a concern. How do you equate a cost to it? And the cost of buying animal is also not cheap. The medical bills if they get sick, or insurance if you do buy insurance for a pet. All this do cost money. But also, how do you equate, I guess, mainly the well-being of the pet, and how is it going to share? Some people in nursing home do get very possessive about the dogs, and they can come into blows and arguments as such as well. As I highlighted before, it's important with the involvement of a user-centric approach in the development of any social robotic, because that can really help with the adoption. So it can serve as an enabler to the adoption and implementation if we use a user-centric focused approach in the development of social robots, because you have the buying of all the key stakeholders. They all have a vested interest. They all have a say what they think is a design, and it actually helps with the adoption and implementation. And finally, true efficacy. Is it meant to be individualized, person-centered? A lot of our research are looking at the efficacy as a group result of the impact on the group. But what about the individual impact? Some people might be more receptive to social robots, get more out of a social robot compared to somebody else. So there's a lot of varying factors. So it's really often very hard to determine the true efficacy of social robots for the older population, or for anyone especially, because sometimes the individualized efficacy might be greater than you're expecting, or greater than what has been determined through a group approach. All right. So in the final part of my presentation, I'd like to actually just present to you a recently published feasibility study of assistive technology called DreamPad. The impact of DreamPad on sleep, wandering, and agitated behavior in people living with dementia. It was only published this year in Geriatric Nursing. Now, what we know is that, or the background to this research is that we know that sleep disturbance are common in people living with dementia. There are well-recognized reports of change to the sleeping patterns of people living with dementia over and above the normal age-related sleep disturbances. Now, besides experiencing sleep which is shorter, lighter, and more easily disturbed, people living with dementia also have more fragmented sleep-wake cycle, with more sleep occurring during the day and less at night than healthy older people. Now, sleep disturbances are further amplified for people living with dementia with Lewy bodies, further to the alteration in the circadian regulation of sleep and changes in the duration and maintenance of sleep. Dementia has also been linked to a sleep-wake disorder emerging in the late afternoon or evening that is known as sundowning. The severity of cognitive impairment is an important predisposition factor in the development of symptoms of sundowning. Okay? Now, when an older person with dementia experiences sundowning, they are more likely to have disruptive behavior such as wandering, agitation, incoherent vocalization, confusion, and even disorientation in the late afternoon. So what we know is around 10 to 25% of people living in aged care facility do exhibit signs of sundowning. So it's quite common, where wandering has been estimated to occur in over 60% of those living with dementia. Now, what can happen is these behavior increase burden of care and risk of fall for older people in aged care, including those living with dementia. Now, effective strategies to improve sleep in people living with dementia, particularly those in nursing home, are needed. However, to date, there have been limited options apart from the use of pharmacological intervention like medication, and literature review of sleep in residential aged care reported really limited benefit, and there are quite concerning side effects in the use of medication or the use of pharmacological intervention to address sleep disturbances. Now, there is also review that indicate that although there is promising support for psychosocial interventions such as exercise, music therapy, light therapy, aromatherapy, CBT, cognitive behavior therapy, even acupuncture, valerian, Ingen San, to help with sleep disturbances, the outcomes and the protocols in the use of these psychosocial interventions are really inconsistent. Bottom line is further research is needed to identify optimal treatment with feasibility and pilot testing, followed by rigorous testing to verify beneficial outcome. Now, so we come across this sleeping device, this sleeping assistive technology device, which is DreamPad. Now, DreamPad is a sleeping device developed in the US that delivers low-frequency rich music through a gentle calming vibration, which is carried internally by the cranium to the cochlea that only the user can hear. The process brings about a relaxation response from the body, amid which is been described as a massage to the nervous system, and it is supposedly useful to reduce stress, improve sleep, that is falling and staying asleep, as well as decrease sensory hypersensitivity for those who are using it. Now, basically, you can see in this picture, basically DreamPad is like a pillow slip, a very nicely padded pillow slip that you put over your pillow, existing pillow. You can then put another pillowcase, so you have your pillow cushion itself. Then DreamPad is a very nice padded case, and you can put it over. You sort of put it over your pillow. Now, you can choose to sleep directly on DreamPad, or if you like, you can put another pillowcase over DreamPad. Now, you can see there's the wire connection in DreamPad that allows you to plug to a mobile phone or MP3 player that play music that you can hear when you're sleeping on DreamPad. Now, what type of music? It's usually sound, just music, not singing rock music as such. DreamPad do come with a preset of recommended music that is soothing and calming, that is conducive for sleep. But that doesn't mean you can play any other music. But it'll be interesting to see, the impact of different music as well. Now, DreamPad uses a multi-sensory program for improving brain function using this technology called infrasound technology. So as I said earlier on, or as you probably know, human bones are natural conductors. When a person speaks, the vibration caused by the voice is carried through the bone to his inner ear. Now, infrasound technology replicates this natural process through using transducer to convert the properties of sound to vibration. Then the vibration is carried through the middle and inner ear, which is home to the cochlear and vestibular apparatus, which governs one's ability to hear and filter out unwanted noise. I guess those are related to the auditory hypersensitivity. Now, so the sound wave then activates the parasympathetic nervous system via the vagus nerve that regulates stress in order to help people sleep better. So it doesn't matter whether you're sleeping on your head, on your side, the bone in our skull will act as a conductor. Now, there are promising results in the use of sleep pad, dream pad, actually, not sleep pad, dream pad, to improve sleep in people with ADHD, people with self-reported poor sleep and insomnia. Now, given the theoretical scientific, I guess, foundation behind dream pad, and given its preliminary research in the use of dream pad for people with sleep disturbance, people with ADHD or insomnia seems to be quite promising, we decided to do a small study to examine the use of dream pad to improve sleep, wandering, agitation behavior, or agitation in people living in dementia in a nursing home. So the study aimed basically to look at feasibility and acceptability of dream pad and explore its impact or its effect on sleep disturbance, wandering, agitated people in people living with dementia, in residential aged care or nursing home. So the methodology is pretty straightforward. We use exploratory case study design where we had 4 residents with dementia, all age 65 years and over, no auditory impairment, had an MMSE score of 26 and below, and more importantly, a recent history reported by staff or family of sleep disturbances, as well as wandering and agitated behavior. Now, we asked the 4 participants, to use dream pad daily for 4 weeks. And the measures we've undertaken is demographic data before the intervention, the baseline data. We also examined their agitation by the Cohen-Mansfield Agitation Inventory short form before and after intervention. And we actually asked participants to wear an actigraph called SenseWear to assess step count that reflects wandering, as well as their sleep duration and efficacy of sleep for each participant. Now, we asked participants to wear the SenseWear for a 24-hour period once in baseline week and also once in each week of the intervention. So all up is basically 5 recordings of 24 hours, 1 per week, including baseline. Now, we also created a measure checklist, as you can see here. So because we can't physically be there at the nursing home 24/7, we had staff to complete this checklist, 1 for each participant, identified by name and ID, that it keeps a record of whether they used dream pad, whether they wore SenseWear, when they were required to, when, for how long they wore it, etc. And also to record any notes of any concern regarding the use of dream pad or the use of SenseWear. Was there any particular anomaly with that resident who is part of the study during the data collection period? Any anomaly that could relate to wandering, agitation, and even sleep disturbances. All right. So we also conducted interviews, semi-structured interviews with family and staff members to solicitate their perception of the feasibility and acceptability of dream pad, as well as its effect on sleeping patterns, behavior, wandering, and agitation. So we're interested in terms of their perception of dream pad, whether these perceptions change over time, or at any time when the residents or their loved one was using the dream pad. Did they notice any improvement or decline in the sleep patterns, behavior, wandering, and agitation? What benefit or limitation do they see in the use of dream pad? Why? Were there any concern about the use of dream pad? What were these concerns? Dream pad costs about $530. What were the perception of the cost of dream pad? Should facility buy it, or do you think it's something that family could be asked to contribute to the cost of? So this was a range of different questions that we asked in the interview with staff and family members. So on this slide is the demographic characteristic as well as the dream pad usage and agitation scores for the 4 participants. Now, as you can see on this slide, the mean age of the 4 participants, 2 male, 2 female, is about 89 years of age. They had an average score of MMSE score of 9.3. 3 of the participants live in the secure dementia unit with either vascular dementia or Alzheimer's disease. The remaining participant resided in low care with age-related cognitive decline. Overall, participants used DreamPad 82% of the time. There was paired sample t-test done to look at the difference before and after intervention on agitation score. There was no significant difference between agitation score before and after intervention. As you can see, no significant difference in agitation pre-post test score. Now, in terms of SenseWare, it actually, on this slide, it shows the number of hours that they have actually used SenseWare. All right. And the usage time is not great. They did not wear the SenseWare long enough for the full period that we expect them to. So it did have an impact on our collection of data when it comes to wandering, when it comes to sleep. All right. Now, on average, participants only wore SenseWare for a total of 14.8 hours out of a maximum 120 hours. A detailed breakdown of the use of SenseWare was reported in the previous table that I've just shown you. Now, in this table, it actually shows participants' step count over 24 hours as recorded by SenseWare during baseline and also across the 4 weeks of intervention. It's not really that meaningful. I mean, it's nice to see what happened, what was recorded here, but it's not really that meaningful because it doesn't really give a good reflection of what really occurred because of the lack of the wear time with the SenseWare. Based on what we can see here, there seems to be not much difference, like step count pretty much remained the same, or there was a slight decrease, or then a little bit of a hike back at the end of the intervention. The only anomaly is participant B, where there's something must have happened in week 2 where he has a huge spike in step count. All right. Now, this next slide provides the lying down time and also the sleep time, whether it's light sleep, deep sleep, or very deep sleep for each of the participant. Now, again, the data is very limited by the wear time of the SenseWare. So it's only interesting to look at the patterns here. And just looking at the patterns alone is not enough. We need to look at what happened to the participant, what are the plausible explanation, and try and look at the bigger picture in terms of their wear time of the SenseWare, their agitation score, their step count, their sleep, and look at the record that we got if there was interesting notes that might have explained what has happened. Now, in the published paper, there was a description of what happened with each of those 4 participants, participant A, B, and C. In this presentation, in the essence of time, I don't have the time to go into depth for each participant. I'll just talk about participant A. Now, participant A wore SenseWare device as scheduled, but did attempt to remove it over the 24 hours period. Care staff who were interviewed reported a noticeable improvement in her nighttime sleep and reduction in behavior of agitation and wandering. Now, this reduction was also reflected in her agitation score, where there was a drop of a score of 25 to 20, which was reflected earlier in the table, as well as the step count and sleeping pattern recorded by SenseWare. Okay. As specifically, care staff commented that participant A slept well on the night she was using DreamPad. However, staff also noticed that participant A did find DreamPad annoying and disturbing, and on some occasion took the MP3 player out of a pillow. On those nights, she was observed to have poor sleep when she was found to be awake, sitting on a bed, and staff noticed she was more depressed as a result during the day when she did not have adequate sleep. This information was all noted by the care staff on the checklist and may have explained participant A unusual sleep pattern that was recorded by SenseWare, especially in week 2 where there was no sleep recorded as such. So really, with this study, given that it's a small sample size, the case study design, and given the issue with the data collected, it was interesting. It highlighted the challenges of conducting the study to give future direction with the research. But in terms of result, we try to present it more descriptively. And then looking just means a standard deviation to perhaps explain or explain the qualitative feedback that we got from staff. It's not about finding statistical significance here as much. In general, DreamPad has been found to be feasible for use by people living with dementia. Although there were some participants that expressed irritation with the music that was heard through the DreamPad, they still continue with the intervention. However, it did highlight the potential that DreamPad might be found irritated by some participant who then proceed not to be willing to use it. So there's the potential there. The cost and use of DreamPad was acceptable to family and care staff. I guess the cost of $530 in the view of family and including care staff is not very high, and if family are prepared to fork out the money to buy, if the efficacy of the use of DreamPad on sleep, wandering, and agitation can be established. Now, what we know is that from this study, it looks like DreamPad may improve, potentially could improve sleep in people with sleeping with dementia. However, the influence on behavior of agitation and wandering is very unclear from this study. Now, we fully acknowledge that there is quite a number of limitations of our study, and therefore we got to interpret the findings or the result of our study very carefully and in light of this limitation. So limitation includes small sample size, study design, which is the case study design, poor wear adherence of SenseWare that actually have an impact on the data collected, but the data collected could mean we could have better data that give us a better outcome or even a poorer outcome. So that is a real limitation. There was also reports of concern about the use of ActiveGraph. SenseWare included in the accuracy of ActiveGraph in recording step count, so that is also an issue. But a lot of studies do use SenseWare and ActiveGraph to measure step count, so it's not a new form of data collection method as such. We also say that there is, while we ask care staff to write on the checklist what participant or if there was any issues or concern that relates to sleep, wandering, agitation behavior on the checklist, we still don't have insight into what participants were doing over the 24 hours where they were meant to wear the SenseWare. So a lot of the key information relating to the data collection period was not actually collected that could have provided us with further insight. And also there is inconsistent and irregular use of DreamPad that has to be taken into consideration. Now, all this limitation and the challenges we experience in this study is important because it really informs us on future study in terms of design, the challenges that we have to overcome in the conduct of the research. And it's really useful information. While it's not, we haven't got a really robust study, we haven't had great result, but we have learned a lot from the conduct of this study, which is really helpful and useful for future research in the use of DreamPad. Now, I guess our final take-home message or the final conclusion we come to is that DreamPad can potentially be incorporated in daily use to address sleep and possibly agitation and wandering if efficacy is established through larger scale study, more rigorous studies in the future in this area. Now, in this last slide, I'd like to present to all of you my mentor, Professor Wendy Moy. One of a take-home message for those of you who are still an early career researcher is to actually find and work with a good mentor. A good mentor will mean a great deal of difference in your academia life, in your research life. I was very fortunate to have Wendy as my mentor. She leads research in robotics in aged care and dementia care. And I was very fortunate to have her as a mentor and be part of a research team and learn and establish myself over the years in research relating to aged care and dementia care. Last year, she's one of the 30 women in robotics you need to know that was listed by RoboHeart, a US non-for-profit organization. This year, she was even listed as one of the world's 50 most renowned women in robotics by Analytics Insight magazine. So I provide the link here. Have a read of these articles. This is a lovely picture of her with Paro, but I highlighted a quotation in one of the magazine. Is that as our life expectancy continues to extend, the world faces a new and challenging growing challenge, which is dementia. Professor Wendy Moy's research on the use of robot as a therapeutic tool could change the face of dementia care globally, while allowing people to stay in their own home longer. So with that, I'll come to the end of my presentation. Hopefully you have enjoyed my presentation and take away some information on assistive technology, namely social assistive technology or social assistive robotic in the form of telepresence robot and social companion robots. So thank you, everyone. Thanks, everyone, for listening. I hope you have enjoyed my presentation. Bye.